Welcome to the Deep Dive, your shortcut to being truly well-informed. Today, we're plunging into really one of the most significant shifts in global healthcare, the rapidly aging population,
Yeah, it's happening everywhere.
especially here in the United States.
Yeah.
This demographic change is happening at, well, an unprecedented rate.
It really is.
We're talking about profound impacts on our healthcare systems, which makes specialized care for older adults just crucial for every nurse.
It's absolutely true. As people live longer, they naturally face a, higher likelihood of managing chronic illnesses.
Makes sense.
Consider this, 92% of older adults have at least one chronic disease, and most, actually about 77%, have two or more.
Wow.
So the key insight for nurses here isn't just a statistic. It's a fundamental understanding that effective care for this population demands a truly holistic, integrated approach.
And that integrated approach is exactly our mission for this deep dive. We're giving you a focused look into Chapter 31, Older Adults, from Varkarola's Foundations of Psychiatric-Mental Health Nursing.
A classic text.
Right. Our goal is to extract the most essential insights for you, the nursing students, covering everything from mental health assessment and therapeutic communication to major psychiatric disorders, psychopharmacology, evidence-based interventions, and vital safety measures.
And it's all framed for real-world clinical practice.
Exactly. And of course, for NCLEX readiness.
You'll gain practical insights and clear explanations, and we'll verbally describe key assessment tools so you can fully grasp them without needing, the actual book in front of you.
Yeah, visualizing those is key.
We'll also walk through real-world scenarios, bridging that gap between textbook knowledge and the nuanced realities of caring for older adults.
Okay, so let's unpack this by starting with some fundamental truths about aging and maybe challenge some common myths along the way.
Good place to start.
Society often holds misconceptions, right?
Yeah.
Like believing most adults over 65 have dementia.
Oh, that's a powerful myth to debunk. While cognitive decline is a concern for some, it absolutely does not affect the majority. That's just wrong.
What's another one?
Another common and kind of harmful stereotype is that sexual interest just disappears with age, or that older adults can't learn new tasks.
Right. The facts paint a much more accurate picture. Yes, senses like vision, hearing, taste, and smell do naturally decline somewhat, and muscular strength decreases.
Sure, those are physical changes.
But maintaining sexual expression remains important for many. And crucially, older adults are perfectly capable of learning new things.
Absolutely. As nurses, maintaining a positive, respectful attitude towards older adults is just vital for providing good care. It sounds basic, but it makes a difference.
It really does.
It's also important to consider the changing demographics. The older adult population is growing rapidly, with racial and ethnic minorities being the fastest growing subgroups.
So that means cultural competence in nursing care is more critical than ever.
Exactly. And with women generally outliving men, understanding their unique healthcare needs becomes even more paramount too.
And when we talk about age, we need to remember chronological age is often just, well, an arbitrary number, isn't it?
Totally. Someone who is 70 might be functionally much younger than someone who is 65.
So instead of strict age brackets like young old or old old.
Right. The real takeaway for you as nurses is to focus on an individual's functional ability and their personal needs, not just the number.
That makes sense. Function over number.
And what's fascinating here is that while physical changes are part of aging, later life is often marked by profound losses.
Yeah, talk about that.
Think about retirement. It can mean losing a career and maybe a big part of one's self-identity.
That's huge.
And there's the loss of loved ones, spouses, sometimes even children, friends. As self-care becomes more challenging, individuals might lose independence or the familiarity of their home environment.
Little things add up too. Right?
Yeah, even diminished senses like taste or hearing impact daily life and can lead to social isolation. It all connects.
And these losses can unfortunately contribute to mental health challenges in late life. And this brings us to a really crucial point for future nurses.
Yeah.
Psychiatric issues like depression and cognitive deficits are not normal parts of aging.
Say it again, not normal. They're diagnosable and, most importantly, treatable conditions.
Treatable. That's key.
Exactly. The problem is they're often underdiagnosed and undertreated. But proper diagnosis and treatment are fundamental because they prolong an individual's independence and ability to make personal choices, significantly enhancing their quality of life.
Okay, so let's explore some of the most common mental health issues you'll encounter. First up, depression.
Right. Mood disorders in older adults are often missed because their symptoms can easily be confused with, other medical conditions or even with early signs of dementia or delirium.
So how do you tell the difference?
Well, the challenge for nurses is distinguishing between them. A careful, systematic assessment is crucial. You need to focus on three cardinal differences: the onset and course of the mental status change, the patient's level of consciousness, and their attention span.
Onset, level of consciousness, attention span.
Got it. Those details are key to accurate diagnosis and getting the right intervention.
And unfortunately, depression can elevate suicide risk, particularly for older men.
It's a serious concern.
For white men aged 65 and older, the risk can be significantly higher, like 7 times higher, than for females of the same age. And it's highest in those 85 plus. It's a really sobering statistic.
And suicide in this demographic is often underreported. The numbers don't always capture instances of passive or indirect suicide, like an older adult stopping life-sustaining drugs, or maybe just losing the will to live. It's subtle sometimes.
Yeah, harder to track. Research into why older adults attempt suicide, like a study from Sweden, offers some important insights.
What did they find?
They found that common reasons included a desire to escape, maybe reduced functioning or autonomy, psychological problems, physical pain.
Feeling like a burden is a big one, too.
Right, feeling like a burden, social or family conflict, and just a lack of meaning in life.
These findings really highlight a critical nursing role in suicide prevention. You have the ability to screen for and identify those at greatest risk.
And that guides intervention.
Exactly, which then guides targeted interventions like maybe increasing socialization, suggesting interpersonal therapy, or making environmental changes to support their well-being.
Okay, so what about treatment for depression?
Well, selective serotonin reuptake inhibitors, SSRIs, are often first line, especially if anxiety is also present.
And if there's pain involved?
Right. If a patient has chronic pain, serotonin norepinephrine reuptake inhibitors, or SNRIs, might be prescribed. They can help with both. For treatment-resistant depression, sometimes psychostimulants can be considered.
What about ECT?
Yeah, electroconvulsive therapy, or ECT, can actually be a highly effective and safe alternative for older adults, particularly those who haven't responded well to medications.
Good to know it's still a viable option.
Definitely. Beyond depression, another common and often debilitating challenge older adults face is anxiety. Generalized anxiety disorder is the most prevalent.
And you mentioned something specific, fear of falling.
Yes, fear of falling, or FOF. It can significantly restrict activity, almost like agoraphobia in some ways. People become afraid to leave their homes.
Wow. What are the risk factors?
Psychosocial risk factors include things like childlessness, low socioeconomic status, and past trauma. But on the positive side, social support, spiritual beliefs, physical activity, and cognitive stimulation are all protective factors.
So treatment, similar to depression.
First-line treatment for anxiety, much like depression, involves SSRIs, often combined with cognitive behavioral therapy, or CBT.
Okay, now here's a critical caution for nurses.
Right.
Benzodiazepines.
Yeah.
Things like lorazepam or alprazolam, diazepam too.
Right. These are often inappropriately prescribed for older adults. Their use significantly increases risks of falls, fractures, mental decline, and even delirium.
That's serious.
It is. And there's even a potential link emerging between chronic benzo use and an increased risk of Alzheimer's disease later on, so these drugs should really be avoided if at all possible in this population.
Good warning. Okay, next let's talk about delirium.
Okay, delirium. This is an acute, time-limited medical condition caused by underlying physiological changes.
Acute meaning rapid onset.
Yes, it develops rapidly over hours to days. It's characterized by a fluctuating level of consciousness and changes in cognition.
And the crucial takeaway here.
The crucial takeaway here is that disorientation in an older adult should never be simply dismissed as, oh, it's just dementia. Big mistake.
That's a fundamental nursing insight. When assessing for delirium, it's absolutely crucial to get a baseline of the person's usual functioning.
How do you do that?
From family or caregivers. Think about asking questions like, was your mother shopping and cooking for herself last week?
Mhm.
Or does she normally pay her own bills?
Practical questions.
Exactly. Red flags like new confusion, maybe unexplained falling, or suddenly disrobing or fighting with staff should immediately trigger an assessment for delirium.
And treatment for delirium focuses primarily on identifying and treating the underlying cause.
Like what?
This means investigating new medications, a recent fall or head injury, drug reactions or toxicity, infections like a UTI, or even electrolyte imbalances, thyroid issues.
Lots of possibilities.
Yeah, vitamin deficiencies, stroke. A multidisciplinary approach involving pharmacists, geriatricians, psychiatric consultation is often necessary to really nail down the exact cause.
Okay, shifting gears slightly to neurocognitive disorders
Yeah.
like Alzheimer's and vascular disease.
Yeah.
What are the hallmarks there?
These are characterized by a functional decline along with specific cognitive changes. You might hear terms like aphasia,
Which is,
difficulty finding words. Then there's apraxia, which is difficulty carrying out motor functions even when they're physically capable, like using utensils.
okay.
And agnosia, the inability to recognize familiar objects or even people sometimes.
And you mentioned executive function.
Right, disturbances in executive functioning. That means difficulties with organizing, planning, abstracting, and exercising good judgment or insight.
Can you give an example?
Forgetting how to make a familiar family recipe or suddenly being unable to manage finances or pay bills are classic examples of that executive dysfunction.
And sadly, this impaired insight often makes older adults with these disorders highly vulnerable, right?
Highly vulnerable to exploitation, yes. Another significant concern is alcohol use disorder.
In older adults.
Yeah. While heavy drinking may decline with age overall, it remains a really serious problem for some. Late-onset alcohol problems are often triggered by major life changes like retirement, widowhood, or profound loneliness.
And identifying these issues can be difficult because the personality and behavioral changes are often missed or just attributed to aging.
Exactly. So when there's any suspicion, screening is essential. A common tool you should know is the Michigan Alcoholism Screening Test Geriatric Version, or MSTG.
MAST. Okay, what is it?
It's a 24-question yes-no questionnaire. Pretty straightforward. A higher score indicates a greater likelihood of alcoholism. 5 or more points usually indicates a problem. It's a quick, vital screening tool for early identification.
Good to have in the toolkit. What are the symptoms of misuse?
Symptoms of alcohol misuse in older adults can include confusion, malnutrition, self-neglect, unexplained weight loss, depression, falls, diarrhea, incontinence, decreased functional status, failure to thrive.
So a lot of overlap with other conditions.
A lot of overlap, and even alcohol-induced dementia, which primarily affects that executive functioning we talked about.
Is there hope for treatment?
What's really encouraging is that older adults respond to treatment as well as, if not sometimes better than, younger adults. Even brief interventions, group therapy, and self-help groups like Alcoholics Anonymous can be highly effective.
That's good news. Okay, let's transition now to pain management. This is a core nursing responsibility, right?
Absolutely huge. Pain is incredibly common among older adults, affecting up to 85% of this population, and it profoundly impacts their well-being and quality of life.
And it's often linked to chronic conditions.
Like arthritis or diabetic neuropathy, exactly. And here's where physical and mental health really intersect. Depression can cause or increase the perception of pain.
And vice versa.
And chronic pain is linked to depression, low self-esteem, and social isolation. The good news? Treating pain often improves mood, and treating mood often improves pain. It works both ways.
But there are barriers to accurate pain assessment, aren't there?
Oh, definitely. Significant barriers. Older adults may believe pain is just, a punishment or an inevitable part of aging, or they might fear appearing weak or complaining.
And on our side, as healthcare professionals.
External obstacles include inadequate assessment by us, maybe assumptions that pain is simply part of aging that needs no intervention, or communication deficits.
So what does this mean for nursing assessment? How do we get around these barriers?
Well, beyond using the standard numerical scales, you need to start with open-ended questions like, tell me about your pain, any aches, soreness, or discomfort.
Using different words.
Right, because older adults might understate their pain using milder words like discomfort or hurting instead of pain. It's also crucial to observe behavioral changes in nonverbal patients, grimacing, guarding, restlessness. And always include family or caregivers in the assessment. They know the person best.
Okay, let's talk tools. The Wong-Baker Faces Pain Rating Scale. Can you describe that?
Sure, you've probably seen it. It uses a series of 6 faces, visually ranging from a big, happy smile representing no hurt, that's a 0, all the way to a crying, grimacing face representing hurts worst, a 10 on a 0-10 scale, though the faces themselves are often numbered 0, 2, 4, 6, 8, 10, or just 0, 5.
Okay.
Patients, even young children or those with some cognitive impairment, can often just point to the face that best represents how much pain they're feeling right now. It's very intuitive.
Simple visual. What about for patients who really can't communicate verbally, like those with advanced dementia?
Right. For them, the pain assessment in advanced dementia or pain aid scale is invaluable. It's mentioned in box 31.2 and figure 31.4 in the text.
Okay, how does pain aid work?
This tool evaluates 5 observable behavioral domains. First, their breathing. Is it normal or maybe noisy and labored? Second, negative vocalization. Are they moaning, groaning, crying out? Third, facial expression. Are they smiling, sad, frightened, or grimacing?
Okay, 3 down.
Fourth is body language. Are they relaxed, tense, pacing, fidgeting, or rigid? And fifth is consolability. Can they be comforted by voice or touch, or are they inconsolable?
And how do you score it?
Each of those 5 domains is scored from 0 to 2, giving a total score ranging from 0 to 10. A score of 1 to 3 suggests mild pain, 4 to 6 moderate, and 7-10 severe pain. It guides your assessment and intervention when the patient can't tell you themselves.
Very useful. Okay, moving to management. Non-opioids.
Acetaminophen, like Tylenol, is often preferred for mild to moderate pain, but you have to be mindful of liver toxicity, especially with chronic use or higher doses.
And NSAIDs. Ibuprofen, naproxen.
Right. NSAIDs like ibuprofen or naproxen can be effective, but they carry risks of GI bleeding or kidney issues, especially in older adults. And the FDA has strengthened warnings about their risk for heart attack and stroke. COX-2 inhibitors like celecoxib might have fewer GI side effects, but still carry cardiovascular risk.
What about chronic pain?
For chronic pain, sometimes pain modulators like gabapentin or certain antidepressants, like the SNRIs we mentioned, can be effective alternatives or additions.
Now, box 31.3 in Varcarolas highlights key considerations for pain meds in older adults. Can you summarize those?
Yeah, this is really important nursing knowledge. First, older adults often receive less pain medication than younger adults, which can lead to inadequate relief. Don't undermedicate.
Okay.
Second, analgesics often reach a higher peak concentration and have a longer duration of action in older adults due to changes in metabolism and excretion. So the mantra is start low, go slow. Start with lower doses and titrate carefully upwards as needed.
Start low, go slow. Makes sense.
Third, when starting pain management, especially for consistent pain, administer oral analgesics around the clock initially, maybe every 4-6 hours, not just PRN, or as needed. This maintains a steady level.
Good tip. What else?
If confusion occurs after starting pain meds, don't automatically assume it's the medication. Assess for other potential causes first, because remember, unrelieved pain itself can cause confusion and agitation.
Ah, that's a critical point. Unrelieved pain causing confusion.
Exactly. And finally, always monitor for and proactively manage constipation, which is a super common side effect of opioid use. Stool softeners, laxatives, fluids, fiber. Be proactive.
Got it. What about opioids themselves?
Well, opioids are still useful for moderate to severe acute pain, like post-surgery, but again, often need reduced doses and longer intervals due to potential kidney issues.
But for chronic pain?
The trend now is really to avoid opioids for non-cancer chronic pain whenever possible. The significant risks we're talking, increased fractures, hospitalizations, even mortality, often outweigh the potential benefits for chronic use in this population.
So lots of non-pharmacological options become important then.
Hugely important. We're talking physical therapy, regular exercise, hydrotherapy, heat and cold packs, chiropractic care, TEN, it's transcutaneous electrical nerve stimulation, which uses mild electrical impulses, yoga, biofeedback, hypnosis, acupuncture, massage, Reiki, guided imagery.
Quite a list.
Yeah, reflexology, therapeutic touch, even herbal remedies. The key thing is to ask older adults if they're using any alternative or complementary treatments. They might not mention them unless you ask.
So what's your core nursing role in all this pain management?
It's critical to regularly evaluate the effectiveness of whatever pain interventions you're using, meds or non-meds. Be highly attentive to behavioral changes that might indicate pain. And please remember this fundamental fact. The ability to perceive pain does not decrease with aging.
That's a myth, right?
Total myth. Physiologically, pain perception remains intact throughout life. Don't dismiss the reports of pain.
Okay, great summary on pain.
Yeah.
Let's broaden our view now to some other healthcare concerns, ethics and advocacy. The financial burden seems huge.
It's immense. Older adults' healthcare expenses are nearly 4 times higher than for the general population, and poverty rates are unfortunately significant, particularly among Hispanic and African American older adults.
And navigating insurance is tricky. Medicare Part D.
Right. Part D is for medication coverage, but it's notoriously complex with deductibles, co-payments, and that coverage gap often called the donut hole, plus catastrophic coverage later. It's confusing.
So what's your role as a nurse here?
Your role is crucial in education. You need to be able to educate seniors about resources like patient assistance programs offered by drug companies and direct them to local advocacy agencies like AARP or the local area agency on aging. They have counselors who can help navigate these insurance choices and financial complexities.
Good resources to know. Another big issue is caregiver burden.
Huge issue. This is the physical, emotional, financial, and psychosocial strain on individuals providing care for a chronically ill, disabled, or aged loved one.
The sandwich generation.
Exactly. We often see the sandwich family scenario,
Yeah.
where adult children are caught between caring for their own young children and their aging parents. This leads to really high risks for depression and caregiver burnout.
Are there resources to them?
Yes, thankfully. There are books, online resources, support groups. Organizations like the Alzheimer's Association and the Family Caregiver Alliance offer tremendous support and information for caregivers.
That's vital.
And sadly, sometimes older adults with chronic psychiatric disorders lack family support, maybe due to long-term illness or estrangement. In these cases, community nurses and case managers become absolutely vital. They are often the core of that person's support system.
Which brings us to a related pervasive issue, ageism.
Yes, ageism, basically a bias or prejudice against older people simply based on their age. It cuts across gender, race, religion, socioeconomic status. It's everywhere.
And it has real-world consequences.
Well, absolutely. Ageism profoundly impacts public policy and research funding. It makes it difficult to secure financial and political support for programs specifically geared toward older adults' needs.
And in research.
Historically, older adults were often excluded from clinical trials, especially if they had multiple medical conditions or were taking multiple medications polypharmacy.
So the drug data wasn't based on the people actually taking the drugs most often.
Pretty much. It meant drug information was often based on younger, healthier populations, which wasn't always generalizable or safe for older adults.
Has that changed?
Fortunately, yes. In 2012, the FDA issued guidelines strongly recommending the inclusion of older adults in clinical trials. They recognize that older adults are the majority treated for chronic conditions and that age-related physiological changes absolutely affect how drugs work. It's a significant step toward better, more evidence-based care for this group.
That's progress. Now, on to healthcare decision-making. The Patient Self-Determination Act.
Right. The Patient Self-Determination Act, PSDA of 1990, this federal law requires healthcare facilities like hospitals, nursing homes, and home health agencies that receive Medicare Medicaid funds to provide patients with clear written information about their legal rights under state law to make healthcare decisions, including the right to accept or refuse medical treatment and the right to formulate advance directives.
Okay, let's talk about those advance directives. They're crucial.
Absolutely. There are three main types you need to know. First is the living will. This is a personal written statement detailing a person's desires regarding medical treatment in circumstances where they are no longer able to express informed consent, specifically if they are terminally ill or permanently unconscious.
So it only kicks in under specific conditions.
Exactly. Second is a directive to physician. This is a bit different. It's where a physician is appointed by the patient as a surrogate medical decision maker. It's usually used when the condition is certified terminal, and there are specific state laws about how it's verified and revoked.
Okay, and the third?
The third, and perhaps most common and flexible, is the durable power of attorney for healthcare, sometimes called a healthcare proxy or medical power of attorney. This designates a specific person, an agent or proxy, chosen by the patient to make healthcare decisions on their behalf whenever the patient is unable to do so themselves. It's not limited only to terminal illness.
And these need to be official, right?
Yes, they must be in writing, signed, and witnessed according to state law requirements.
What if someone lacks capacity and hasn't made an advance directive?
Then we might be looking at guardianship or conservatorship.
Yep.
This is a legal relationship created by a court order where a guardian is appointed because an individual is found to be incapacitated and unable to manage their personal or financial affairs. Nurses must be aware of who the legal guardian is to ensure appropriate communication and consent for healthcare decisions.
So what's the nurse's role in all this decision-making? Box 31.4 covers this.
Your role as a nurse is vital. You're often the one responsible for explaining the facility's policies on advanced directives and helping patients and their families understand these documents. You need to ask on admission if they have an advance directive and ensure it's in the medical record.
And you'll encounter different codes, status orders.
Right. You'll commonly see three approaches to care reflected in physician orders. Full code, meaning all life-saving measures will be initiated. Then DNR-CCA, which stands for Do Not Resuscitate Comfort Care Arrest. This means all medical care will be provided until the person experiences a full cardiac or respiratory arrest, at which point resuscitation efforts like CPR, intubation would not be started, but comfort care continues.
Okay, and the third.
DNR-CCO, Do Not Resuscitate Comfort Care Only. This means the focus is entirely on providing comfort, relieving pain and suffering, and promoting quality of life. Medical care is not aimed at cure or life prolongation, and invasive procedures or resuscitation efforts are withheld.
These can lead to really complex ethical dilemmas, can't they?
Oh, absolutely. For example, deciding whether to continue or remove a feeding tube in a patient with a DNR-CCO order can be incredibly difficult for families and staff.
What helps then?
Hospital bioethics committees are invaluable resources in assisting with these difficult situations. They provide consultation and help navigate the ethical dimensions.
Important point. Nurses must intervene if they see an advance directive isn't being followed correctly.
Absolutely, you have an advocacy role there. But remember, you generally cannot assist a patient in actually writing or witnessing their advance directive, as that could be seen as a conflict of interest. You explain, you educate, you advocate for their documented wishes.
Okay, good clarification. Let's move into comprehensive nursing care itself and the different treatment settings. Attitude matters, right?
It's paramount. As nurses, your attitude needs to be one of positive regard, respect, and genuine appreciation for the wisdom and life experience older adults bring. Forget the stereotypes.
And assessment needs to be broad. You mentioned the comprehensive geriatric assessment.
Yes, recommended by the NIH and outlined in Figure 31.5. It's multifaceted, really holistic. It covers physical health, looking at chronic disorders, vision, hearing, mobility, nutrition, incontinence, and especially medications.
What else?
Mental health assessment is key screening for dementia using tools like the Mini Mental State Exam, MMSE, and depression using tools like the Geriatric Depression Scale, GDS. It also looks at functional status, activities of daily living or ADLs, economic and social status, support systems, and environmental factors like home safety.
You gave some great tips for conducting assessments earlier. Privacy, rapport.
Yeah, those basic communication strategies make a huge difference. Conduct the interview privately, introduce yourself clearly, ask what the patient prefers to be called. Establish rapport, sit or stand at the same eye level, make sure lighting is adequate and noise is low, especially if there are sensory impairments. Use touch respectfully, only with permission. Always summarize what you heard, invite feedback, and thank them for their time.
Yeah, and always do a physical assessment first.
Absolutely. A thorough physical assessment, often including diagnostic tests like thyroid function, kidney and liver function tests, CBC, CMP, B12, folate levels, maybe even neuroimaging like a head CT, must precede any diagnosis of a primary mental illness. You have to rule out underlying medical causes for cognitive or mood changes first.
Okay, and then there's medication reconciliation. What exactly is that?
MedRec, as it's often called, is a formal, systematic process of reviewing all the medications a patient is currently taking. That means prescription drugs, over-the-counter meds, vitamins, herbal supplements, everything, and comparing that list to the physician's orders.
Why is this so important?
The goal is to create the single most accurate, up-to-date list possible. This is crucial for preventing medication errors, like omissions, duplications, dosing errors, or dangerous drug interactions, especially during transitions in care like hospital admission or discharge. It's a major patient safety initiative.
Which ties directly into polypharmacy.
Exactly. Polypharmacy, simply meaning the use of multiple medications, is extremely common in older adults. And the risk of adverse drug reactions, ADRs, increases exponentially with the number of drugs taken. The risk roughly doubles for people taking 5 to 7 medications, and it quadruples for those taking 8 or more.
Wow. And you mentioned a Beers list.
Right. The American Geriatric Society maintains and regularly updates the Beers criteria for potentially inappropriate medication use in older adults, often just called the Beers list. It identifies specific medications or drug classes that should generally be avoided or used with caution in older adults because their risks tend to outweigh their benefits in this population.
including some psychiatric meds.
Yes, unfortunately, many common psychiatric medications are on the Beard's list or require careful consideration, including benzodiazepines, certain antipsychotics, and some antidepressants, due to risks like falls, cognitive impairment, or anticholinergic effects.
And then we have the problem of prescribing cascades. Can you explain that?
Sure, a prescribing cascade happens when a side effect from one drug is misinterpreted as a new medical condition, and then another drug is prescribed to treat that side effect.
Creating a domino effect.
Exactly. It creates this downward spiral where polypharmacy increases, the patient experiences more side effects, and conditions become even more complex and harder to manage.
Can you an example?
A classic example is when an antipsychotic drug causes Parkinsonian side effects, like tremor or stiffness, and then an anti-Parkinson drug is added, which might cause its own side effects, like confusion or constipation. Or maybe a cholinesterase inhibitor used for dementia causes urinary incontinence, leading to an anticholinergic drug being added to treat the incontinence, which then worsens confusion.
Ugh, sounds like a mess.
It can be. This really highlights the critical role pharmacists play in reviewing medication regimens and the importance of nurses carefully monitoring for and reporting potential side effects before they trigger a cascade. The negative consequences are huge increased costs, more ADRs, drug interactions, problems with adherence, functional and cognitive decline, falls, incontinence, malnutrition.
Okay, let's zero in on mental status exam tools.
Okay.
The Geriatric Depression Scale, GDS short form.
Yes, that's in box 31.7. It's a great subjective screening tool. It's a 15-question yes-no questionnaire that the patient completes themselves, or you can read it to them.
How is it scored?
Certain answers, usually bolded in the form, indicate potential depression. A score of more than 5 points is suggestive of depression, and a score of 10 or higher is almost always indicative of depression and warrants further assessment. It's quick and easy to use.
Good screening tool. What about objective measures for depression, especially with dementia?
The Cornell scale for depression and dementia is often used then. It's an observational checklist completed by the clinician based on interviews with the patient and caregiver looking at behavioral signs of depression.
And suicide assessment, always critical.
Always. We mentioned the risk earlier. You need to ask direct questions. Have you ever thought about ending your life? Are you thinking about harming yourself now? Do you have a plan? Do you have the means to carry out the plan?
What if they just express a death wish, like I just wish I would die?
You should never ignore comments like that. While it might not indicate active suicidal intent, it signals significant distress. Explore it with active listening, empathy, and provide immediate support. Find out why they feel that way. If there is active suicidal intent with a plan and means, the individual requires immediate intervention and should not be left alone. Documentation and reporting according to facility policy are essential.
Another safety issue. Driving.
Yes, driving and the older adult can be a really sensitive but important safety concern, especially if cognitive impairment or physical limitations are present.
What are the signs of unsafe driving?
Evidence might include things like failing vision or hearing screenings, documented cognitive deficits, impaired mobility or reaction time due to things like arthritis or movement disorders, a history of frequent minor collisions or near misses, getting lost in familiar areas.
So what's the nurse's role?
It's often about observing, documenting, and communicating concerns. You might consult with the primary medical provider who can assess fitness to drive or make referrals. In some states, there may be a process for notifying the State Bureau of Motor Vehicles for an official driving evaluation, but this varies and often requires physician involvement. It's tricky territory.
The case scenario in the book about Jose is a great example of navigating this sensitively.
It really is. Jose, 75, had moderate to severe cognitive impairment and was driving erratically, clearly unsafe. But his family, due to cultural respect for elders, felt they couldn't just take his keys away, which they saw as undermining his authority.
So what did they do?
Their creative solution was to disable the car itself, remove the distributor cap or something similar so it wouldn't start. Jose still had his keys, maintaining his sense of dignity and authority, but the car was undrivable, ensuring public safety.
That's clever and respectful.
And importantly, the family also ensured he had everything else he needed. Medication reminders, good nutrition, social routine which allowed him to safely remain at home despite his cognitive issues. It highlights that patient-centered, culturally sensitive approach.
On a more difficult note, older adult abuse. What should nurses look for?
Abuse unfortunately takes many forms. Physical abuse, hitting, shaking, improper restraint, psychological or emotional abuse, verbal assaults, threats, isolation. sexual abuse, financial exploitation, misusing funds or property, and neglect, withholding necessary care, food, medication.
How do you assess for it? Box 31.8 gives some tips.
Yeah, interviewing requires skill and sensitivity. Gather preliminary data first. Maybe use short questionnaires. Ask about often overlooked problems like sleep, appetite, or fears. Pace the interview appropriately. Don't rush. Use simple, direct questions if there's cognitive impairment. Start with general opening questions like, how are things going at home? Or, how are you being treated?
Exploring relationships.
Yes, explore key relationships. Who helps them? Who do they rely on? Are they afraid of anyone? Assess their mental status. Review all their medications carefully. And whenever possible and appropriate, include family members or significant others in the assessment process for additional input or corroboration, while also ensuring you have private time with the older adult.
Okay, let's shift to interventions, the general approach.
A key thing to remember is that patient-centered care, where the patient is an active partner in decisions, might actually be a new concept for some older adults who grew up with a more paternalistic healthcare model. So consistent reinforcement and explanation might be needed.
What about psychotherapeutic methods?
The foundations are empathetic understanding, active listening, and encouraging the ventilation of feelings, letting them talk. Normalizing their emotional responses can be very validating. The goal is often to help reestablish emotional equilibrium. You'll also provide health education, assist with problem solving.
Patience is key too, right?
Absolutely. Allow adequate processing time for their responses. Don't interrupt too quickly. Ensure communication aids like hearing aids or pocket amplifiers are working properly. And provide important information in large print written format whenever possible.
And psychosocial interventions.
These are really valuable.
Yeah.
Things like individual or group counseling can help build relationships and reduce feelings of isolation. Cognitive stimulation is another one, engaging in activities that exercise the brain, like physical and mental exercises, word games, puzzles, listening to music, discussions of past events, which overlaps with reminiscence, and activities aimed at improving language skills.
And you mentioned reminiscence.
Yes, reminiscence therapy. This involves encouraging patients, often in a group setting, to talk about past positive events and pleasant memories. It's great for socialization, building rapport, and can significantly improve mood and self-esteem, especially for those with some memory impairment.
Moving to psychobiological interventions, mainly medications. What's the nurse's role?
The geropsychiatric nurse plays a vital role in monitoring, reporting, and managing medication side effects. You need to be vigilant for things like acute dystonia, sudden severe muscle spasms, often in the neck or eyes, akathisia, intense inner restlessness, pseudoparkinsonism, drug-induced Parkinson's symptoms, and tardive dyskinesia, involuntary movements, often of the face and mouth.
Serious potential side effects.
And also rarer but life-threatening ones like neuroleptic malignant syndrome, NMS, characterized by fever, muscle rigidity, altered mental status, autonomic instability, or serotonin syndrome from too much serotonin activity, causing confusion, agitation, sweating, tremor, hyperreflexia. You also monitor for common anticholinergic effects like dry mouth, blurred vision, constipation, urinary retention, confusion.
So lots of physical assessment involved.
Constant physical assessment. Monitoring vital signs, assessing pain levels, reviewing lab results, monitoring elimination patterns, observing gait, implementing fall prevention strategies. It's comprehensive.
Box 31.9 has great tips for medication teaching for patients and families. Can you hit the highlights?
Yeah, practical tips for you to teach them. Always read medication labels carefully. Ask questions if anything is unclear. Make sure the entire healthcare team knows about all medications being taken, prescription, OTC, herbal, supplements. Keep track of side effects and report them. Keep all doctor and lab appointments.
Memory aids are helpful too.
Definitely. Use memory aids like a weekly pill box or a medication calendar. Write down important information. Bring a trusted friend or family member to appointments for a second set of ears, and recommend they do an annual medicine checkup with their doctor or pharmacist to review everything they're taking.
Great advice. What about interventions only advanced practice nurses do?
Advanced practice registered nurses, APRNs, with psychiatric specialization can provide individual and group psychotherapy. They might use approaches like cognitive behavioral therapy, CBT, motivational interviewing, interpersonal therapy, or psychodynamic therapy to address specific mental health issues, reduce social isolation, and improve overall quality of life.
Okay, finally, let's walk through the different treatment settings for older adults. Where might they receive care?
It's really a continuum of care. For the most acute conditions, severe agitation, psychosis, active suicidal intent, major depression requiring intensive treatment, you have geropsychiatric units. These are specialized inpatient hospital units.
What's key there?
They use a multidisciplinary team approach, and the nurse's role in milieu management is huge. That means structuring the environment, ensuring safety, adjusting stimuli, choosing compatible roommates, making sure call lights are within reach, preventing falls, reducing noise, anticipating patient needs, and skillfully de-escalating agitation before it requires more restrictive measures.
And the nurse leads in crises.
Often, yes. The nurse is often the crisis team leader because they have that 247 knowledge of the patients, their medical conditions, and their baseline behaviors. They guide the team during acute events to prevent injury and, importantly, facilitate post-crisis debriefing to learn from the event.
What about skilled nursing facilities or nursing homes?
Skilled nursing facilities, SNFs, are increasingly being used for older adults with severe and persistent mental illness, sometimes controversially. There can be concerns about care being more custodial and staff education on mental health being inconsistent.
And their protections?
Yes, federal legislation, like the PSDA we mentioned, and nursing home regulations, OBRA 87, protects residents from unnecessary drugs and physical restraints. There's a strong emphasis on trying non-pharmacological interventions first.
So the nurse's role is advocacy?
Big-time advocacy, ensuring residents get appropriate psychiatric evaluations, overseeing medication management, monitoring behaviors closely, notifying physicians of changes, and participating actively in care planning. There are very strict regulations governing the use of restraints, both chemical and physical, in SNFs.
What about less intensive settings?
There's assisted living, which provides housing, meals, and 24-hour support, but usually for individuals needing minimal to moderate assistance with activities of daily living, ADLs. It's often private pay, not covered by Medicare.
Respite care.
That's specifically designed to prevent caregiver burnout. It provides planned short-term breaks for family caregivers, either in-home or facility-based.
Residential care.
This often refers to group homes or other settings aimed at supporting community living, though they can be underfunded.
Partial hospitalization programs, PHPs.
These are for ambulatory patients who need structured activities and therapeutic supervision during the day, but don't require 24-hour inpatient nursing care. They go home at night.
And daycare programs.
Two main types here. Multi-purpose senior centers often offer health promotion, social and educational activities, and sometimes meals. Then there's adult daycare, which typically provides more supervision and assistance with custodial needs for adults with cognitive or physical impairments, allowing them to remain living at home while giving caregivers a break during the day. It also helps maintain social ties.
Home health care.
This is for older adults who are homebound due to illness or disability. Nurses and aides provide care in the patient's home, assisting with illness management, medications, wound care, therapy, etc. It often helps those with cognitive impairment, medical issues, or stable serious mental illness, SMI, to remain in their homes longer.
And finally, community-based programs.
These aim to promote independent functioning and reduce family stress. They often involve case management to coordinate various services like Meals on Wheels, transportation, homemaker services, and connections to other community resources.
Wow, okay. So wrapping this all up, what does this mean for you, our listeners? We've covered a really comprehensive range of essential concepts today.
Yeah, everything from understanding the complex realities of aging and how to properly assess mental health disorders and pain,
To navigating those tricky ethical decisions around advanced directives and identifying the wide array of care settings available.
So as you embark on your nursing career or continue in it, remember this. Older adults bring a lifetime of experience and wisdom. Your role as a nurse, especially in mental health, is not merely about managing symptoms or conditions.
It's much more than that.
It's about truly listening, advocating fiercely, and providing holistic, person-centered care that honors their dignity and actively works to enhance their quality of life in their later years.
And maybe leave you with this final thought. Consider how your empathetic approach, your willingness to truly see the person behind the age or the diagnosis, can fundamentally transform the healthcare experience for this vital and rapidly growing population. Your care matters deeply.
On behalf of the Deep Dive team and the Last Minute Lecture team, thank you for joining us on this crucial exploration of caring for older adults.
Remember, as future mental health professionals, you are not just building knowledge, though, that's critical. You are also building empathy, which is truly fundamental for providing holistic, patient-centered care. Keep learning, keep caring, and we'll see you on the next Deep Dive.